Hey Sonia,
Hello. How are you?
I'm good. Just take me a minute to get off mute. How are you?
I'm okay. You look like you have something glowing around your head with your
I have
background.
I'm at home because my cubicle at work doesn't have walls, so I can't control background noise, so it's easier for the virtual meetings to just do it from home. And I have my
No.
kid drew this rainbow and it's on the bulletin board.
Oh, yeah. Okay,
Probably should
okay.
just take it down because it looks like I have a
You have a halo.
oh,
No, no, no. Leave it. It's cute. It's cute. Leave it
it's distracting. I'll put it back later. I don't know. It might not fix the problem. I don't know.
up. Oh, you desecrated the kid's drawing.
It'll go back. It's okay. Yeah, I think Brooke is gonna join in a minute, and she's gonna do this, run the slides for us. So, oh, there she is. Hey, Brooke. We've got our RCC captioner on. Can you hear us okay?
I hear you perfectly.
Okay, good. Brooke, you have the slides, right? From I sent that email out to the presenters yesterday, and that had the latest version of the slide deck. Oh, awesome.
Hey, Hope, can you hear me?
I can.
Okay, all right, good.
I haven't heard any. If you said anything before now, I haven't heard it, but I can hear you now.
I don't know why it's so weird. I'm sitting here trying to. I hate WebEx. I absolutely despise it.
Oh,
Yeah, I'm gonna have an issue with this. But anyway, what am I showing on my screen? I can't tell.
um, we can see the slide deck. I think this is good. There might be a way to make it bigger, but like right now it shows it's showing the next slide. So is there a way if you hit the empower, yeah, there we go. Yeah, I think that's the view that we want.
Okay, all right. Okay, all right. So we're good.
Yes, thank you.
All right.
And sorry that you'll have to hop on and off, like when I think Jessica's gonna do a preview of the unwinding dashboard.
Okay.
And then a little bit later, Will is gonna do a preview, but Will's will be towards the end of the meeting. So you can probably just actually shut down the slide deck after that point.
Okay. All right. Trying to figure out. Okay, so you can still see. You don't see the next slide. You still see the original, right?
Yep, yep,
Okay.
and I think it's probably as big as it needs to be.
Okay. All right.
Yeah, Sonia, does that look good to you? She might have hopped
Perfect.
off, but
No, I'm here.
I can see it just fine.
Okay. All right. Good.
Yeah.
Well, once y'all start, I'm going to mute myself and then I will be listening for y'all to tell me next slide.
Okay, and I'm gonna post the link for captions in here. Might need to do that again after the meeting officially starts, but hey, Sarah.
Hey, Hope, can you hear me okay?
Yep.
Okay, great. Guess you can just give it a few minutes, let people join, and then let me know when you think we have quorum. Seems like we're kind of late right
I
now.
think we're pretty far from it now.
Yeah.
So I'll keep an eye on the attendees and let you know.
Thanks.
Hello?
Hi, we're on. We're just waiting for enough members to join where we can start the meeting. So thank you all for your patience, and hopefully we'll have enough folks at 1 or just a few minutes after 1.
Hello?
Sarah, at this point, we have a quorum, so if you want, we could go ahead and get started, or we could wait another minute to just make sure everybody that's joining is on.
Thanks, Hope. I think we'll give it just a minute just to make sure if anyone's having some technical issues, they can get on, and then we'll get started. But for folks who are here, as you know, one of the first things we'll have to do is vote on adopting the minutes from last meeting. So if anyone wants to do something with their time, feel free to start skimming over those and be ready for the vote. Okay, we can get going. So thanks everyone for joining us for today's virtual CHIPAC meeting. I'm Sarah Cariano, I'm the chair. And we have a pretty packed agenda with lots of folks here to share good information today. So we can go ahead and get it kicked off. Hope did post in the chat how to view the live captions for the event. So that'll be there. And then also just a reminder that our virtual meetings are recorded and they'll be posted on the DMAS website. So just be aware of that and, choose your camera use accordingly. Next, we'll just have to do roll call. So if we can forward to those slides, you can either say here or type here in the chat. And I'll just go a little bit slow just to make sure that we have time to get it recorded. So Irma Blackwell.
Here.
Dr. Brickhouse. Dr. Brown.
I'm here.
Kelly Cannon.
Here.
Me, I'm here. Martha Crosby.
Here.
Heidi Dix. Ali Farouk.
Here.
And Shelby Gonzalez. Great. We can go to the next slide. And as that is advancing, if anyone is here as a substitute, feel free to just say here and give us your name when we get to your organization. Emily Griffey. I think Emily was here and then maybe logged out, was having some issues, so hopefully she'll be back. Alexandra Javna.
Here.
Estelle Obi Tabat. And Estelle, if I messed up your last name, I apologize.
That's right. It's Estella Ubi-Tabit, and I'm here. Thanks.
Thank you for joining us in Jeff's place today. Jennifer McDonald.
Here.
Freddie Mejia.
Here.
Michael Muse.
Here.
Emily Roller.
Here.
Hannah Schweitzer.
Here.
Dr. Webb. Okay, we can go to the next slide. All right, that's it for roll call. Thank y'all. So this
Sorry,
is
Sarah, this is Shelby. I was a minute late, so I might have missed one. But I'm here.
Hey, Shelby, glad you
Hi.
could join us. So we'll move right on to CHIPAC business. And as you can see, the agenda for today is up. The first thing we'll have to do is review the minutes from the March 2nd meeting and vote on them. So they were in the member packet, the meeting packet that Hope sent out earlier, if folks could just take a second and review them. And when you're ready, I'll need a motion and a second to approve.
While y'all are reviewing, I just wanted to, I don't think anybody said this yet, but just wanted to make sure it's clear the meeting's being recorded.
It was a meeting, but very informative. So motion to approve.
So Kelly Cannon, motion to approve. Is there a second?
A second.
And I think that was Freddie that motion to second. All those in favor, Hope, for virtual, for recorded purposes, do you want people to vote in the chat for votes?
That might be easiest if you're not able to type in the chat for some reason, if you could say your name and say yay, but everybody else at this point, this is the only vote that I think we have for this meeting. So if you could type with the view where it says to everyone, just type yay or nay. Okay. All right, I think we're good to go.
Awesome, thanks everyone. Especially as we're kind of still figuring out somehow the best practices for virtual meetings. We only have one membership update. Dr. Brickhouse, who's been on CHIPAC for quite a while, is she and her family are moving, and so she'll be stepping down. She was kind enough to send a few suggestions for new members to replace her. And we'll discuss those at the executive subcommittee meeting that's coming up in July. Anyone can join those meetings. So if you do want to join, or even if you want to join just for the discussion of new members, feel free to let Hope know and she'll give you the calendar invite and login information and all of that. And if you do have other members or other thoughts of organizations or members that you think would be a good fit for CHIPAC, I know that there are a few spaces open. So, you can always send those suggestions to Hope and I, and we can bring it to the executive subcommittee meeting at the appropriate time. I think that's it for member updates. So everyone's favorite topic, Virginia and Medicaid unwinding. Is Jessica on for us today?
Hello, I am here.
Great. Thank you so much for joining us. Jessica, please take it away.
Sure. So I'm going to go pretty quickly through the slides that we have today. Actually, I kind of skimmed over the meeting minutes from last meeting, and a lot of this information is probably going to be the same. But at the end, we'll be showing you something on our DMS website that I think will be pretty interesting to see, and also be able to answer any questions maybe that you've had since the last meeting and now. So we can go ahead to the next slide. So this, of course, is our general updates or background slide, and a lot of this hasn't changed because it's what's been done in the past. So I'm going to go ahead and skip to the next slide just because this is all old information, basically. How did we get to where we are today? I believe we have this March number updated on the slide for the last CHIPAC meeting, but just in case. So we did see a 41% growth in enrollment between March of 2020 and March of 2023. So as you can see, that's a little over 630,000 members. Our enrollment was fastest among basically that expansion population. And we continue to look at our churn and our loss estimates. Those seem to be about the same. So our loss is looking to be about 14% with our churn, which means coming back within 1 to 6 months of an additional 4%. So go to the next slide. All right, and so this just gives you a little bit more of the information on what we did to prepare for the unwinding. As everyone knows, the Cover Virginia contract went through a pretty sizable modification to not only staff up to be able to handle the additional calls, but also to be able to take on that additional renewal assistance. So the Cover Virginia vendor can help us with basically cases that don't require discretion, which is a lot of those families and children's cases or MAGI cases that we talk about in this group here. So that helps us to kind of break down the work. What we expect is that about a third will be automatically renewed, and then the other 2/3 will be split among the Cover Virginia staff and then the local agencies as well. And then, of course, outreach and education. This group has been key in that, and I'm sure you guys have seen all of the flyers and toolkits and all of the great information that the state has put out regarding the unwinding. And we did see a lot of you at our Operations Unwinding Summit. It went back to the last slide, but I kind of remember what's on here, given this presentation a couple times. We had over 300 people attend that summit, from stakeholders to other agencies. A lot of the people, like I said, on this call attended. So wonderful turnout for that. We were really appreciative that everybody could come together. I think for a lot of people, that actually was the largest in-person event since March of 2020. So it was really great to get everybody together so we could hear each other's perspectives and learn what we are going to be doing during unwinding. So then the next slide, please. And this goes a little bit more into, the local agency planning and collaboration. So some things that we did to update our system, and I'll talk about that in a little bit as well, are no-touch, actions that we take care of so that way the workforce can focus on the more complex cases, those ABD and those long-term services and supports. So we did make some changes with that. We did also, look at things that can promote consistency so that every member is treated the same through any automated process. And then also, we have a lot of reporting that we put in place. CMS has asked for a lot of reporting. And then also we wanted to make sure we were training so that as issues arise, we already have the reporting in place so we can track those trends and figure out what we can do to make the processes smoother. And then training and information centers, we definitely give Irma and her team major props for this. They were able to develop e-learnings and SME-led webinars. As you can see, that over 3,000 local agency staff completed the training. Those formal trainings did conclude in April of 2023. However, they are actually performing, I believe, weekly calls with the local agencies at this time to still get their questions answered, to help, as things come up, because of course, you may think you have all your questions answered, but it's not until you start working those cases that some of those questions come up. And then, of course, our collaboration with some of our other external partners, our health plans. We continue to collaborate with them not only to receive their contact information updates, but they're also helping us with a lot of the outreach that's required to meet our requirements for the Consolidated Appropriations Act. A lot of that having to do with making sure not only are you getting the information, but are you completing it and turning it in? Excuse me. And then with the State Corporation Commission, we are working with them as well, even though we're not state-based yet. That's going to be just around the corner. But we've been working with them as well to make sure they understand our processes now, as they do get phone calls today. And then when we do transition to that state-based exchange, we'll be able to make sure those transitions stay smooth. Next slide, please. And I think we've gone over the outreach and engagement strategy. So of course we're full force in phase 3. That's where we're starting to see those closures coming in. Those non-procedural or basically people that are determined ineligible, those started effective April 30th. And then those procedural closures for not returning information, basically we weren't able to determine their eligibility. Those started yesterday, May 31st. And so phase 3 is helping with that outreach for those procedural closure reasons to make sure that people understand you don't have to go through the full application process. You can turn in your renewal or turn in those verifications and we can take a look and see if you are eligible. That's even important because even if they're not eligible, of course, the only way to potentially get someone to the marketplace is if we truly determine they're ineligible. So that's part of that outreach as well, is even if they think they're not eligible, we can try to help connect them with other coverage they could find eligibility in. We'll go to the next slide. And so some information and resources here. We do have, of course, our member and stakeholder resources and materials. I think at this point, pretty much everybody on this call has been to our Cover Virginia pages as well as our GMAS website. So of course, we just want to keep you updated on those as more things come in. You will start to see some things archived, of course, things that were policies that were in place before the end of the continuous coverage requirement. Some of those informations will start archiving, but of course that means we do have copies of them. So if there's ever something that you wanted to look at from past experience, you can just let us know and we'll be able to get that for you. Then, of course, there's a couple dashboards that are relatively new. They've been out for a few months, but it's the first time really we've talked about them in this group. We have our renewal status dashboard, and I believe we're going into that, right after I'm done with the slides here. And we'll kind of go into that. I'll explain it to you, show you where it is on the website, and also how you can see how we're tracking those redeterminations through unwinding. And then we have some legislative resources and information. The link, of course, is on here. You all received the packet of information. And of course, I know Will Frank is also on the call to speak to us about some legislative items a little bit later, so I won't steal any thunder there. I think the next slide is basically the wrap-up slide for unwinding. So before I share my screen and go into the dashboard, I'll go ahead and pause here to see if anybody has any questions, anything they want to bring to the group, anything they've been hearing since we've been in unwinding.
Thanks, Jessica. I just want to remind folks, you can either just ask a question. You're welcome to also type it into the chat if that's easier. And you can always, use the chat during a presentation and we can circle back to it at the end of a presentation. So
yes, and I'll be here.
Ask away.
Yeah, as I say, I'll be here throughout the entire meeting. So if anything comes to mind, of course, anybody can ask and we can get back to that or get back with you. And as you're thinking, to be completely honest, not having a lot of questions is still pretty normal from what we've been hearing. We check with Cover Virginia on a very regular basis, and because, like I said, those closures when they've occurred and the time it may take for a member or household to receive their notice, we're not seeing a lot of those questions coming in yet. We've just started to see some appeals are coming, through. Not, a huge number, which is good because we want everyone to be able to kind of have that ramp up, to when the volumes will get a little bit higher. But that's kind of been the message across the board. I think that this might be the first month in which we do get a little bit more of the questions and the outreach, just because this is when we're starting to see a little bit more of those closures occurring.
Jessica, I do have one question. Do you have data on how many closures happened yesterday?
So we get our first set of data for that around the 5th. And I'll also talk about that when we're talking about the dashboard. So I don't have exact numbers yet on the closures because we have to do our our research and vetting on those. But as soon as we're able to get those, we do share them out with also our ambassador group. And also, like I said, when I go into the dashboard, that will kind of help to let you know when some of that will be updated.
Do you guys have data on just how many termination notices were sent?
Not offhand, no. That's part of what we have with the data we get on the 5th gives us a little bit more of that information.
Jessica, this is Emily with VHCF. Do you mind if I ask a question about thinking about the returned mail and the outreach via MCOs? It was my understanding too that the local agencies are also doing some outreach. I was just curious. I know the 2 additional modalities was the standard. Can you share a little bit, or I don't know if maybe the DSS might be better equipped to share about what that looks like and what members should expect potentially from local agencies?
Sure. So I can go ahead and give an overview of what we've done to kind of preempt before receiving returned mail. Because as CMS actually, they also posted some revised FAQs that go into this as well on their website. So in order to meet the requirements for the Consolidated Appropriations Act, states can actually provide that dual modality outreach prior to receiving return mail. And so that's what we are doing for our managed care through our health plans, and Granicus is our fee for service vendor that we're using for that population. And so what's happening is we're actually doing that modality outreach or after the renewal forms are set. So before we even know whether or not we're going to get return mail, we're actually doing that proactive outreach in the multiple modalities. And that would be phone, email, whatever's available. We're going to try to text, we're going to try to call, we're going to try to email, whatever we have on file. We're getting some information back on if we're getting bounce backs and things like that. Of course, that doesn't help us in how we can get in touch with them, but we're starting to be able to gather the information on how successful is it? Are we getting a lot of bounce backs? Again, because we're just starting to gather that, I don't have any information offhand on that, but that's something we can always bring to the next meeting. And so in terms of what will happen if return mail comes in, definitely Irma, definitely layer on, or if I'm forgetting anything, but there's not a lot extra that can be done if return mail comes in because we've already done the outreach, but it should be a best practice for workers to review the information, make sure there wasn't a typo in the address, because sometimes you can tell just by looking at the mail. Oh, the street name was wrong. I know this is an apartment complex and I need to go find the application and put the apartment number on. Or if there is a forwarding address, the yellow stickers, CMS has given us guidance, which we've also passed to social services and the locals to follow up if there is a forwarding address on return mail. So really that's going to be the biggest follow-up. Of course, the locals are able to perform a secondary outreach to any of those modalities. But I also just want to make sure everybody understands we were proactive in our outreach. So that way, before we even get the return mail, it could possibly help, someone turn in their renewal in an alternative method online or by phone. So I didn't know if there was anything that I left out there. Definitely want to make sure I don't miss anything.
Hi, everybody. I don't know if you're receiving any feedback, but I've been experiencing audio issues since I performed a restart today, and I can't turn my volume up very high without receiving a very loud screeching sound, so I apologize. So no, you're right, Jessica, with everything that you've said. What we have advised staff to do, in addition to what you've said, is if there's an email on record or a telephone number on record and there's mail that has been returned, we have asked that they perform, that they get in touch with try to get in touch with the household that way as well if they're unsuccessful at reaching out through other means. I am having some problems with hearing what you have said, but I agree with what you said, but we have put some guidance out to the local staff to let them know that if there is an email or a telephone number to reach out by that method as well, so that we can cover all bases.
Right, a clarifying question, Irma, if I can, and that's at the same time that the renewal goes out, or is that in response to the follow-up or to, excuse me, the mail being returned?
That would be in response to any returned renewals.
As Irma added there, we're hitting them on both ends. We're gonna just go ahead and reach out to them when we send it, regardless of if we know it's a correct information or maybe it's been updated and we don't know. And then of course, if it is returned, there's gonna be another outreach touch. So
I'm not seeing or hearing any more other questions. Jessica, I think if the dashboard was next.
yes, I believe so. So I will go ahead and share my screen. Oh, it's been a while since I've done this on WebEx. Okay. And let me move my thing over here. All right, I think you guys should be able to see the DMAS website. So of course, let me try to see. So, okay, now I can see you guys. Perfect. All right, so very familiar with our DMAS website. To get to the unwinding dashboard, you will go under our data tab. And our friends that help us develop our website were so nice as to put our dashboard at the top. So that way that is highlighted. So there will be some additional things on this website, but we're going to go over to the eligibility redetermination tracker. And so what this is this is an overall status. So what this is looking at is basically when we started unwinding, we had what's called a cohort. We had a group of people we knew we needed to touch and redetermine. So we want to know every month what happens to that group. So as we can see here, the metrics of the dashboard is refreshed every month. As of now, that is refreshed on or on the 8th, unless the 8th falls on a holiday or a weekend, and then it'll be the next business day. I will let you know there are some updates being made to that. The frequency is one of those. We do want to get you, refresh data a little bit more regularly. They're still working on that though, so I don't have an exact time frame on that, but just know right now it's refreshed every month on or about the 8th. Doing math in my head, the 8th, I believe, is next Thursday, so we should be seeing that refreshed on the 8th. So there are some buttons here that go over the 3 different populations. I'm not going to go and click on these, but you can click on these as you navigate to it. We've also received some feedback that these names, these groupings of the cohort, which is the larger group that needs to be touched, they're a little confusing, and so we are looking into basically renaming these. So we have 3 groups of individuals that will go through this process out of the entire cohort. You're either going to be someone that needs a redetermination, you'll be someone that was closed, or you'll be someone that was renewed and your coverage continues. So you can see how we call one of the cohorts redetermination completed. It's a little bit of a misnomer because you could have been closed as a result of your redetermination. So those are the ones we're kind of looking at renaming to something more like coverage renewed or coverage closed. So you'll see some changes there in the future. And so again, this just gives a little overview that shows the current month status. And then we'll go ahead into the dashboard itself. I'm going to make it a little bit smaller just so I can get a little bit more data on here. If anybody thinks that's too small and I need to zoom back in, just let me know. And so what this is this is giving us each month. It is a snapshot of where we were at the end of the previous month. So right here, you can see it says May. This is what we refreshed in May, meaning what happened by the end of April. There's a couple different ways you can look at the data. You can look at program, meaning if you wanted to break it down between fee-for-service or those enrolled in managed care. Eligibility categories, and there are, I don't want to think about this like covered groups because there could be multiple covered groups within the same eligibility category. For example, famous is not separated from Medicaid, so both your Medicaid and your famous children will be under children. Enrolled due to pregnancy would be pregnancy-related Medicaid, but if you were to have a pregnant adult that was, let's say, enrolled in expansion, they would be under the non-APD adults. So there's a little bit of information, and thank you, Sarah, for sharing the link in chat. So there could be multiple groups within this. Then, of course, the reporting period. So again, this is as of May 1st that we refreshed on the 8th, and it's reflecting what happened in the previous month. So I'm going to scroll down just a little bit because I want to show you our cohort. Our cohort here is 2,166,381 individuals. So that was the total number that we saw on March 1st that we knew that we would have to touch and do some sort of redetermination on. Now, of course, as you know, we gain new members every day, but this cohort is who we knew as of March 1st that we would need to redetermine during winding. So even though this number, changes every month in terms of redetermination needed, if you were to add all of these numbers together, you should always get back to that 2,166,381. So again, we break this down into the 3 different groups, and just for purposes, it's going to be closed, renewed and continued coverage, and redetermination needed. We also do color code these. We have graphs, we have numbers, we have percentages, just a couple of different ways of looking at the information. And as I tell a lot of people, even though this is purple, it's kind of maroon. I'm a Hokie alumni, and as much as I would love to see my maroon, the goal is actually for this color to go away because we want to make sure we're getting through those redeterminations during unwinding. So far, we're on the right track. We're seeing that color go away. We're seeing a little bit more of the green and more of the yellow as well. And like we've said, because we should not be seeing a lot of closures on the dashboard at this point when it refreshes for June, of course, we'll be seeing some more of those closures due to procedural closures. Right now, the majority is actually going to be those that were renewed. Then we have a table down below that also breaks that out again by numbers and percentages, so that way you have a couple of different ways of looking at that data. A couple things that I want to point out that have been attention since the dashboard was first published in April. If you break this down to look at it, for example, by eligibility category, if you look at it from one month to the next, you may notice the numbers don't add up. Well, that's because sometimes someone's eligibility category changes. It doesn't mean that their actual eligibility changed, though. And aged adults is one of those where it can happen. As you know, we're not allowed to move someone without a full redetermination, even if they would have typically moved in the past because of something like aging out. So all of those expansion individuals that are turning 65 do end up shifting to the aged adults population, even though we may consider them non-ABD adults because they're currently enrolled in expansion. However, if you look at all, you will still go back and get that sum. So it's a little bit wonky if you're trying to track based on eligibility category. That's really more just if you want to see fluctuations, but the number at the end is always the same. So it's a little bit tricky if you're trying to track with that because there may be people who move within definitions of eligibility categories, even though their eligibility itself has not moved. Another thing is these percentages. This is something we've asked to look at. I do not know the status of whether or not we're going to be able to change these percentages. But if you notice, I did filter back by aged adults, and these percentages become very low. So these percentages are back to that 2.1 million number that we started with. It's the percentage compared to the entire cohort, the entire population. So this is not 4% of just the aged adults. So just another thing to explain there. So those were some of the things that have been brought to our attention so far. The last thing I was just going to bring up is, of course, redeterminations completed. Of course, ex parte is going to play a big step in this in the first couple of months while we're waiting for those renewal forms to be returned and processed. Just a little bit on ex parte, so everybody knows, ex parte is our automated no-touch renewal process. It is our process that takes that manual work off of the, off of the shoulders of the local agencies. What we have noticed, of course, which is what was expected, we are continuing for those cases that are currently due, meaning they have a current renewal date, they're kind of going through the normal process as always. Those rates are staying the same. We're still at a 60% success rate for those overall. Our overdue cases, which means that they were attempted in the past, they weren't successful, we're trying them again because we do have to try them again per federal guidance. Those rates are a lot lower. They're really only at about 10% right now. That is expected because, of course, if they weren't successful in the past, the likelihood of them being successful again is low. But as we talked about on one of the previous slides, we did put in some systems changes to help some of those cases get through the process, and if not, send those renewal forms. So again, to even see an 11% success rate for those really old cases, because we're going oldest to newest, is still an improvement because, of course, it could have been 0 because they had been unsuccessful in the past. So just wanted to break that down because overall, of course, if we were just to say the ex parte rate is 25%, that doesn't give the full story. We are tracking it, the current due renewals versus overdue as well to make sure we're not slipping back on current due, which we're not. I think that's everything I have for the dashboard, of course. We have the link in the chat and any questions about the dashboard so far.
Jessica, I have one question.
Sure.
If someone through the redetermination process has moved from a full benefit category to a limited benefit category, are they counted as a closed member or a redetermined renewed member?
They would be redetermined and renewed because at the time that this dashboard is pulled, their coverage is ongoing. So basically, they're still enrolled with us, and then that actually would be one of those things that where you would then maybe look at limited benefit and you would maybe see some of those numbers climbing because we know, which is a great thing. Some of our expansion members in particular have gained employment, but they still may be plan first eligible, so they may shift from full to limited. But yeah, they would be reflected as redetermination completed or renewed and coverage ongoing.
Right. Any other questions on that?
Hey, Jessica. I'm not, so I know you mentioned maybe changing some of the terminology that's on the dashboard. Are there any plans to add additional, kind of columns or rows of information as we start getting some of those procedural disenrollments?
Yeah, we do have some data on that. A lot of our dashboard also goes through our secretary's office for review. So of course it's not just UMass's decision what is put out there. And so we are looking at that information to see, if there is anything else that we can add. I know that's definitely been a topic of discussion is procedural versus non-procedural. However, when we did look, even though we knew we wouldn't receive those, our preliminary results, even though we don't have numbers for May, is actually a vast majority were not procedural closures. Now we'll get a little bit more because that was before cutoff, and we know that the way the local agencies work, you're kind of closing those cases for procedural reasons closer to Medicaid cutoff. But we were really happy, especially for April, to see that a lot of the reasons for things like moving out of the state, a death was reported, a customer requesting that their case was closed. So luckily it's the reasons we're expecting. But like I said, in terms of the dashboard, we're always looking at what we can do to get more information out there publicly.
Great, thank you, Jessica.
Jessica, I might have missed this and I apologize, but I've been playing around with the dashboard and I've been trying to keep track. I'm trying to figure out where would I look to see how many people successfully made it through an ex parte?
So we don't have that on the dashboard itself. It's the reason is the information for this dashboard comes from our enrollment system. And so when someone is renewed, that enrollment system does not know if it was due to a ex parte, whether it was automated, the worker performing ex parte, or due to an administrative renewal. That is, of course, data that we are keeping track of. But this dashboard and the information that we use for this is from the enrollment system that doesn't track it on that level.
Okay, got it. Thank you.
Mm-hmm.
Can I ask you a question that has to do with the ex parte process? Because I know that as you were talking, it just kind of triggered me because I know that people will go through a second ex parte, as you mentioned. In the ex parte process, are you are you kind of are you, because I've been hearing some states are I would say erroneously, kind of re-looking at things like citizenship and immigration status, which is really probably in general, with maybe some slight exceptions, not necessary, and or, you do have, to the extent that you do feel like maybe for the IKEA group or something like that, like, very narrow situations, you have a lot of data in your case files already. I'm just curious about what that's like, if you all are just skipping that altogether, which is what I think should happen. Anyway, just can you tell me a little bit about that piece?
Sure. Yeah, so the way our automated ex parte process works, and honestly, the way that a manual ex parte, if a worker were to do that, information that is not supposed to be reviewed as part of a renewal, even if that's the administrative renewal, the things that are not subject to normally change, like you said, citizenship, social security number, things like that, that's not even re-verified as part of the ex parte process. Ex parte simply looks to see if we have data sources on file that is able to ensure that income-wise, the household is still eligible, and we only are able to authorize it if it is the same level of coverage or better, meaning we cannot authorize through an ex parte method a reduction or termination of coverage. And so basically, to answer your question, no, we're not looking at that. Now, the only way that I would say that will impact our ex parte is maybe if a document expiration date has passed. What would most likely happen is if someone maybe was CHIPAC or something, or was a permanent resident, it may run eligibility saying this person is eligible for emergency services. But again, because that would be considered a reduction, our automated process wouldn't authorize that. It would drop out, which would send the administrative renewal packet, therefore prompting the household to re-verify that information.
Okay. In general, do people who get the administrative renewal, assuming outside of this exception that you just described, in general, do individuals not have to, re-verify immigration and citizenship status?
Right. And actually, because federal policy is you're supposed to use your data sources even after you send an administrative renewal form, the renewal form simply asks someone to say, yes, this is still the same, or no, it's different, and only if it's different to give us new information. We then take that information, we still have to run it against data sources, and only if there's a discrepancy or we're not able to verify it, that's when we would reach out. So
Great.
if they tell us no, their information hasn't changed, for non-financial reasons, we don't even go back and re-verify.
That's great, because it would be unnecessary. So I'm really glad to hear that. Thank you.
Yeah. And just to give you a little information, I do have ex parte information. I had to go back and find the email. So this is so I think I have a little bit of case level and individual level information. So we had 115,260 households, 200,604 members that ran through ex parte in May. Out of that, we had 29,493 or households, or 52,438. We'll put all this in the notes to go out after the meeting as well, and it'll be in the meeting minutes, that were successfully renewed during the automated ex parte. So again, that's the 25.6% success rate, which is why I wanted to break it down and say 25% doesn't sound great, but when you break it down current versus overdue, honestly, it's what we expected. We're running the oldest cases first. I think as we get into running some more of the more current overdue, if that makes sense as a definition, I think we'll see that percentage go up as well. But we're not seeing a decrease in the current renewals. We're still keeping that really good rate of success. And then we had 66,677 households that were mailed that renewal packet. And those renewal packets, let's see, they were sent, they're probably due, trying to do my quick math in my head, mid to late June, probably around June 18th, I'm thinking is the due date on those. And those, of course, they were sent on the 22nd. So from what we've been seeing for general mailing times, they should be starting to see those probably this week if they haven't already.
I have one question going back to closure reasons. Are you, as DMAS or VDSS, kind of tracking trends, or will be tracking trends as things go on for the non-procedural as well? We've seen a couple cases where the reason listed was for that stated that the member had requested the closure, and the member says that they did not. And so, you know, if that's closed and they never got a renewal packet because the closure reason was saying they wanted it, that seems to be like an end run around a lot of the federal protections. And so I'm just wondering if like there is back end kind of processes built to track and pick up trends if something like that is happening at a larger scale.
Yeah, so we do look at those trends to see, because we do want to make sure we're doing some sort of QA also, even for procedural closures. You know, we want to make sure, okay, you know, is there something which you can only do so much by looking at a system, but you know, making sure that we're tracking those, making sure are people doing their true due diligence and not closing people for the incorrect reason or at the incorrect time. Because also we want to make sure we know that mailing times are, you know, they're a little bit longer. So we want to make sure that people aren't necessarily closing someone on the exact date in which something is due. Give time for mail. Make sure that if a customer reaches out, you need to work with them to make sure they're getting their information. But yeah, we are looking at those, you know, to see what those closure reasons are. And if we do see trends, you know, we definitely collaborate with GSS as well, you know, to pinpoint, is it a specific agency, region? Is it a specific coverage group? Is it something that we need to get outreach to one of our stakeholders to that work with one of our specific communities?
Great. Thank you. Sorry, Emily, did I see you were about to say something? I don't want to cut you off before we move on. Okay. If there's no more questions about that, we do have one more speaker on unwinding. Alex Javno was just going to give a little bit of update on how the Department of Education is trying to interact and educate school systems so that they can help families. So Alex, if you are here, you want to unmute and share, that'd be great. Thank you so much.
Yes, Sarah, thank you. So I'm Alex Javna, Student Services Specialist in the Office of Student Services at the Virginia Department of Education. And I spoke with my colleague, Amy Edwards. She is our VDOE Medicaid specialist, and she wanted to be here today, but she is attending another meeting. So she just gave me her notes on all of her outreach efforts. She's been very busy spreading the word. So I'm just going to go through a few of her activities. And I'll also pop her email in the chat in case you have specific questions that I can't answer for her, because she has been really dedicated to this. So she told me she's been participating in the DMAS Medicaid Ambassadors Task Force meetings, and then recently in March, she had someone from DMAS come and present at her Medicaid coordinators meeting to talk about unwinding with school personnel. This group meets quarterly, so their last meeting in March, this was a focus. And at this meeting, the toolkit was presented, and school divisions were informed that outreach about this is an administrative claimable activity where they can receive partial reimbursement based on the statewide random moment of time study. And they were also informed that a reduction of Medicaid penetration rate would impact their reimbursement. So there were 80 participants at this meeting. At the end of the meeting, they were given 30 minutes in groups to brainstorm on how to provide and spread the unwinding information to their students and families. And this presentation was also emailed to 178 Medicaid contacts in schools. And then in early March, Amy spoke with homeless liaisons regarding the unwinding and the importance of Medicaid recipients to update their contact information. She provided avenues for updating contact information and the toolkit link to all of our homeless liaisons. And then in April, she spoke with the school nurse coordinators and emerging leaders in school nursing, and they received information regarding unwinding and the importance of informing students and families about updating their contact information, and the toolkit was also provided in this presentation. Just last month, Amy presented to the Virginia Association of School Business Officers, and this presentation also included a brief overview overview of this topic with about 40 participants. And then she is very much looking forward to a superintendent's email that will go to all of our division superintendents about unwinding and outreach efforts that schools can do. And she is expecting this to go out very, very shortly, along with the link to the toolkit to support these efforts. So she's been quite busy with this and very hopeful that the superintendent's email will inform lots of school divisions who she hasn't been able to get to. We're hoping that will go out very shortly. So any questions? And I'm going to write in the chat right now her email. If there's anything specific that you would like to know, she'd be happy to connect with you all. And Sarah, is there anything else you need from me?
And I think that is it. Thank you so much, Alex, for sharing. And yeah, please, if anyone needs a connection point for email addresses, let Hope and I know, and we'll happily make sure folks get to the right people with their questions. So thank you, and thanks to Amy, please, for pulling that together for us. If there are no more unwinding questions, I'm sure it is a topic we will discuss again. But for right now, I think we can move on then. So our next is just a little update from DMAS on the language and disability access work that they have. We have Montserrat Serra from who is the DMAS Civil Rights Coordinator. For those of you who weren't able to join, DMAS and Montserrat hosted a really great kind of virtual summit on accessibility with one of our navigators, Carla, and some of her folks at Central Virginia Legal Aid Society and Disability Law Center and other partners. And so I think some of those materials are available, but just really happy to kind of pass it over to her and let her share about some of the really great accessibility work that DMAS has been doing and continues to do.
Yeah, thank you, Sarah, for the great introduction and the kind words about the forum. But yeah, for those that don't know me, I am Montserrat Serra. I'm the Civil Rights Coordinator. And my main role at the agency is to ensure compliance with non-discrimination laws and regulations with the Virginia Medicaid program. In particularly, most of my work relates to language and disability access efforts for limited English proficient individuals and people with disabilities. And that is not only to comply with the law, but also to eliminate access barriers and ensure effective communication and to provide a better experience with the Medicaid program. As Sarah mentioned today, I was asked to come and participate at this event and speak about the DMAS language and disability access initiatives that we have completed so far. And also provide you a little bit of information on the forum on language and disability access that we implemented in 2023. So we can go to the next slide, please. And so before we move on, I thought it would be important to highlight our department's mission and how it really connects with our language and disability access efforts. The Department of Medical Assistance Services mission is to improve the health and well-being of Virginians through access to high-quality healthcare coverage. And if we move to the next slide, please. To put things into perspective, it is important to know that Virginia Medicaid provides health insurance coverage to over 2 million Virginians. Virginia Medicaid's main cover groups, as you most know, are children, pregnant women, older adults, individuals with disabilities, and income-eligible adults. Among our Virginia Medicaid population, we have approximately 5.57% members, as you can see on this chart, who are non-English speakers. That is close to 123,000 members. This chart shows the different languages that the Virginia Medicaid population speaks. And the most frequent language, as you can imagine, is Spanish, but we also have a lot of Arabic speakers, followed by Vietnamese, Urdu, and Amharic. And this chart shows you the percentage and the amount of members that speak those languages. And this chart is also helpful to see trends in language usage among our Virginia Medicaid population. As you can see, we had 5.24% non-English speakers in 2021. And in 2022, this went up to 5.57%. We know that with the unwinding, we might see some of these numbers going down, but the general trend with limited English proficient individuals is that those numbers continue to going up as we acquire more non-English speakers in our Virginia Medicaid population. We can move on to the next slide. So the reason why I show those numbers is basically to understand how necessary it is for our department to continue addressing the language access needs of our Medicaid population. This slide highlights our main efforts that we have completed to date, and it's a very high level. And I will go one by one and just provide a very high level overview of each of these initiatives. We started in 2020, completing an individualized language and disability access needs assessment for the agency. We just needed to evaluate, first of all, what were the language needs of the Virginia Medicaid population. Once we had that information collected, we developed, implemented, and released the DMAS Language and Disability Access Plan. The plan is available publicly on our DMAS website. And that includes language access programs and procedures that the agency currently has in place. And it also documents the agency's goals that we have to continue our commitment to the language access needs of our population. DMAS has been hard at working with updating Medicaid eligibility notices, and some of those updates are to improve language access. And we have some of our notices, eligibility notices, now have or are available into the 5 most frequently used non-English languages among the Virginia Medicaid population. Those are Amharic, the Arabic, Spanish, Urdu, and Vietnamese. Also, some of those updates that we have completed for our notices were or was to include a supplement with language taglines written in the top 17 non-English languages. For those that are not familiar with what language taglines are, those are very short notices about how members can access language interpretation services or translation services. They are short statements and they are translated into the 17 non-English languages. So those that need language assistance services can understand where they need to reach out for language access if they need help with their notices. And part of those updates with the notices were to include a non-discrimination notice supplement. That supplement informs members about how to obtain or their right to obtain language access services for free. Where do they need to reach out if they want to make a complaint, a discrimination complaint, and pretty much informs members of their rights to free language access services. Another initiative that we carried out was more of an internal DMAS agency initiative that was to implement a Spanish language skill assessment among our DMAS staff that are bilingual in English and Spanish. So basically we had some bilingual staff that they were having contact in Spanish and helping the agency with their awesome skills. And we just wanted to make sure that they were competent with both languages so we could document that information. And we designed a language assessment that had like a written portion and a verbal portion so we could document their competency level with the Spanish and that they could continue using their wonderful skills to communicate directly with Spanish-speaking members. We also have hired a digital accessibility officer to ensure all DMS digital communications are 508 compliant as per the Americans with Disability Act. And DMS has drafted language access standards for its interagency agreements, memorandums of understanding with collaborating agencies that serve similar LEP populations. And also those standards include provisions to share best practices to enhance language access services across agencies. Those same standards are also included in our contracts with Medicaid vendors, just to ensure that they are also under the same page as far as providing language access services and non-discrimination language. And lastly, well, no, we have one more. Another initiative is the civil rights training that we have implemented here at our agency among our DMA staff. This is a mandatory training that we started implementing in 2022. And basically the training informs DMA staff on linguistic and cultural competency, so that everyone at the agency knows how to properly serve Virginians with limited English proficiency, and also knows how to serve people with disabilities. That was a great effort the agency did, and the Civil Rights Unit collaborated with the DMS training unit to provide this training. This training is now provided to everyone that starts at DMS.
They had like 586 reviews and 4.5 stars out of 5.
Someone is
Now, unfortunately, it's the
unmuted.
lady on the
So
one of the
if
people
everyone
working there
can
is the
mute.
lady on the billboard when we're pulling into town.
Emily, I think it might be Emily who is with the microphone on. All right, I'll continue unless Emily, yeah, I think it looks like she muted herself. So the last initiative is the Forum on Language and Disability Access. This is something that we started putting in the works a couple years ago. It was included as one of our goals in the Language and Disability Access Plan, and we are so happy to say that we have completed that goal. And on May 15, we had the very first Forum on Language and Disability Access. And what the forum is a series of webinar events that we will be having publicly open or open to the public twice a year. And where we are going to be discussing among Virginia Medicaid stakeholders and state agencies and pretty much the community how to meet the language and disability access needs of communities. Each webinar has an overall language and disability access related theme and features experts from state agencies and community organizations that they discuss a topic kind of like in a panel format. So as Sarah mentioned, during May 15, we had 4 organizations that they were addressing different questions that we had about how they implement language access in their organizations. So that was very helpful information that they all share, and that we're hoping that the community and everyone will gather some new piece of information that they can also bring to their bring to their own organizations to implement those language and disability access procedures. And all the materials, and we can move on to the next slide because I think that's the last one I have. But as mentioned, the forum is a series of public webinars to discuss the topics related to language and disability access Language and Disability Access, and to consult and engage with Virginia Medicaid stakeholders to understand and meet the language and disability access needs of communities. That's the goal of the forum. As discussed, we had the May 15 forum, and in December there's gonna be another one. And if you want to stay up to date with information on the forum, including the May 15 recording and the May 15 materials, you can go to the DMAS website. Just go to the members tab, and there is a section that it's called Forum on Language and Disability Access. And that's where you can obtain more information on future forums and also on all the recordings of the forums that have been already completed to date. So this is all I have for today. If there are any questions, I'll be happy to answer those. And if not, you can always reach out to us for more details if needed.
Great, thank you so much for sharing. If I don't see any questions in the chat, but we'll just give it a second to see if anyone has anything that they want to ask. No? Well, Monserrat, thank you so much for the presentation and your time and all of this very, very important work. We really appreciate you taking some time out to tell us about what you're doing.
Certainly. Thanks for having me.
And the next agenda item is to learn a little bit more about DMAS's role in the governor's initiative with the Partnership for Petersburg and Maternal and Child Health. And Kim Molden from the DMAS Healthcare Services Division is going to share about that. So Kim, are you here and good to go?
Yes, I sure am. Thanks, Sarah.
Great, thanks so much.
So yes, I'm Kim Molden. I'm Senior Operations Lead for Director Roberts and our agency point person on the Partnership for Petersburg initiative, and really excited to share today so much of the work that has happened to date and so much of the work that is left to do going forward. I know many of you on this call are engaged or are familiar with this initiative, but I'll give kind of a little bit of a background first if we can go to the next slide. So this initiative started, the governor launched it in last August. It's crazy that it has now been over 9 months since the kickoff, but there's been a lot of really great progress since then, and it's been really excellent that this is a truly collaborative initiative across all state agencies, really focused on improving the outcomes in the city of Petersburg for the residents of Petersburg, knowing what we know about Petersburg outcomes being some of the lowest in the state. As far as healthcare is concerned, it is the lowest in the state. And knowing that information, knowing, that the life expectancy for Petersburg residents is over 12 years lower than the average Virginian, that child mortality is 180% higher than the state average. Same with infant mortality, that we just see higher rates with cancer, with low birth rate, just across the board on things that we really care about and can do something about in the Medicaid program. So we've kind of been tasked with coming from the healthcare perspective to really address these very dire circumstances for Petersburg residents and see how we can collaborate across state agencies, with community members, with providers, with our managed care plans, contractors like Connexus and DentaQuest, to really do kind of a comprehensive full court press for how can we better meet the needs of these members, of Petersburg residents at large, especially seeing that 2/3 of Petersburg residents almost are Medicaid beneficiaries that we serve through our program. So knowing that we touch so many Petersburg residents really kind of ups the need for us to really respond to this in collaborative, meaningful ways. Next slide, please. So at the gate, at the kickoff, I think at that point in time, there were 42 separate initiatives across all of the state agencies. I'm sure it has likely grown since then. And of those 42, DMAS was really tasked with 3 specific goals. The first, increasing utilization of pediatric, adult primary care, and maternity services to Medicaid members through community events and mobile clinics. To really increasing utilization for prenatal and postpartum services in Petersburg. I think our baseline year of data that we looked at, we saw, I can't remember off the top of my head if it was 20% or 40% of members had not had timely access to prenatal services. That's way too low. We can do better with that. Same with postpartum services, especially now that we have the extended 12-month postpartum coverage period. How do we really leverage that? And then the third initiative that we've been tasked with is thinking through, there is a school-based clinic at Petersburg High School called the Crimson Clinic, operated by Central Virginia Health Services. And how do we kind of expand the services provided through the school clinic to serve family members of students, to provide a wider array of services, and working with partners in Petersburg to see what the options for that are. Next slide, please. So I wanted to kind of quickly touch on a lot of the highlights and progress that we've had to date. Really out of the gate, our main objective was for us and our MCOs and other partners to have a community presence, to be in the community on an ongoing basis, to start increasing familiarity, to help build trust, since we know that so many of our members in Petersburg and Petersburg residents in general have a distrust in the healthcare system with our health plans, with the work that we're trying to do. And so trying to engage with, rebuilding that trust, building health literacy, engaging, building connections and relationships that hopefully, as we move forward with this work over the next couple years, that we can kind of use this as a building block to better engage and get folks into services and build a comfort and infrastructure around increasing access to services, the kind of services that are involved, the engagement of the providers on the ground doing that work. So to date, I think this number has gone up even more since I made this slide, with DMAS, our MCOs, DentaQuest, and Connexus participating in over 100 community events and mobile clinics in Petersburg since this initiative launched in August. That's really fantastic and awesome. And our goal going forward is that each of our MCOs commit to at least one event a month in Petersburg. And what we've seen so far is they have gone above and beyond that, not just doing that one event a month. And we are really excited with increasing access to mobile clinics. A few of our MCOs have mobile vans that they can do to kind of go throughout the community in Petersburg and provide care where members are. This past week, I was at the launch of the Centera Community Care mobile clinic van that will be situated at Petersburg Library and the Hope Clinic throughout each month to provide services at, a trusted entity at the library, central to the community, that, as a walk-up basis, don't necessarily need to have appointments, can, get your needs met on site, and a very comprehensive amount of services will be provided there. So we're excited to see that and, just doing what we can to meet members where they are. So we had the events, we're expanding the mobile clinics. We've had some targeted conversations with providers, and I think this is an area that we're really looking to do more of going forward. We've started with maternity providers, just seeing what we have seen about our low prenatal and postpartum utilization numbers for Petersburg residents and VHHA. Kelly, your team has been awesome with this. I know we need to connect again on that soon going forward. but engaging Bon Secours Southside Regional Medical Center, Virginia Physicians for Women, Central Virginia Health Services, other providers in the community to come together to say, what can we do differently? Who are we seeing? Who are we not seeing? Why might this be happening? We pulled data on where Petersburg members are giving birth, saw that there's a good chunk at VCU, a good chunk at Chippenham Johnston Willis Hospital, both of those quite a trek from downtown Petersburg, trying to understand, what's driving that. Are there any unmet needs that we can, fill those gaps to mitigate the need for that? Building trust locally and resources and capacity and all of that. So starting to have those conversations. We're looking to reconvene that provider group and kind of expand going forward in the coming months. And then thinking through for other population groups, how do we have these targeted conversations where we come together, we look at the data, have the expertise from the people on the ground, both in the healthcare facility and in the community, that can help us understand and troubleshoot kind of what's going on, how to better meet this need, what creative opportunities we might have to serve in a different way than we have been, and getting all of that into motion and collaborating with our health plans, with community-based organizations, other state agencies across the board. And then another thing that we're really excited about kind of on this front is, I mentioned before, the MCOs have been really wonderful about being on the ground and facilitating this community presence, but also we've seen tremendous charitable investments in Petersburg from our managed care plans, and that's been really exciting. Of course, I mentioned the Centera mobile van, and has been doing kind of pop-up clinics as well. We had Anthem supporting financially the Urban Baby Beginnings Maternity Hub that opened recently in Petersburg. That was really exciting, again, to provide additional maternity services, to ramp up doulas available to pregnant and postpartum Petersburg members, and just donations of basic need materials, toothbrush kits, like dental hygiene kits, crevettes for newborns, maternity supplies, books in schools, donating meals and food to those in need, and really engaging with a wide variety of community partners to enable these investments. When I forgot to mention with Connexus and making sure that all of the Petersburg schools had their vision screenings and were connected to eyeglasses if needed. And one of our MCOs stepped in for those who weren't covered under Medicaid and provided funding so that they could have access to glasses too, so that those kids weren't left out of being able to see and engage in the classroom, and having that service provided to them. Oh, thank you for moving to this slide, because I mentioned this on here. So yes, we have, really committed ourselves fully to this initiative, and, we're working to continue to dive deeper in the numbers, to have conversations in the community with members, providers, others, really understand what the needs are, where there are opportunities, what isn't working, what might work that we can try, and continue to iterate and collaborate together, with one of the goals being, of course, increasing the outcomes and the healthcare experience of Petersburg members and residents, but to also really be able to take lessons learned from trying things differently, from being more hands-on and engaged. And, what can we learn from this that we can take to other communities across the state, as we know that Petersburg isn't the only locality with negative healthcare outcomes, that, there are other populations and pockets across the state that would be great to be able to take this work forward with and kind of test there. So that's good news too, that, we're thinking about that at the same time. We're investing a lot of resources and energy and partnerships in Petersburg, connected with the governor's initiative, but then kind of taking the learning beyond, and how do we do this elsewhere to also make an impact. Next slide, please. I guess, so this is the final slide on Petersburg, just really reiterating our commitment. And I also just wanted to make a plug for any CHIPAC members or others on the call, we are regularly looking for opportunities to be connected with different partners to hear different ideas, different ways that we might get additional data that can help inform the work that we're doing, or having a platform for conversations that might facilitate moving this work forward. So please, please, please don't hesitate to reach out to DMAS if you have any ideas, connections in the community, things that we might try differently. I know, especially in the maternity space, we've been exploring a bunch of options of potentially working to get PRAMS data so that we can understand kind of historically what that landscape has looked like from VDH, or thinking about, can we find a provider to engage in centering pregnancy, or just how to so finding kind of opportunities to have these conversations to get new ideas into the fold, and to continue to engage the best that we can. I think that is all that I have for now. I'm looking at my notes real quick to make sure that I didn't forget to mention anything specific, but really, yeah, so out of the gate, we wanted to be in the community, to put ourselves out there, to start building relationships. As we've matured, over time with our learning, now trying to take a deeper dive to really understand and engage and get that community feedback for how we can target our events going forward, while sustaining that engagement and community presence to hopefully build trust. And now kind of moving into the data, how we are holding ourselves accountable, what we're measuring, how we know that we're having an impact. And we've found kind of small ways to do that. Early on, we committed to every quarter looking at our prenatal and postpartum members who have not yet utilized services, and asking our MCOs to do enhanced outreach to them. But we as an agency also writing handwritten letters, hoping that they might be more compelled to open those, if it's not just, a letter from DMAS, that's not, personalized to them, that's just kind of printed out. And we saw with the first attempt that we had on that, I think our baseline number was 40% had, not utilized prenatal services, but we got after that, I think like 3 months after that, kind of MCO enhanced outreach and the DMAS letters, we were able to see that 80% of our members from that cohort had indeed had prenatal services, and replicating that over time, continuing to track that, finding other mechanisms that we can, do little interventions, measure their input, take it to scale if it's working, try something different if it's not. And the Partnership for Petersburg has been a great catalyst for, really doing that work and knowing that there is much impact to be made, if we can figure this out, and just being very serious in our commitment and collaboration there. So again, please reach out if you have any ideas, opportunities, whatnot. Any questions on Petersburg? Because, well, I will note, Hope had mentioned previously that you all had requested a brief update on the procurement. So I will touch on that as well, but I will pause quick before jumping into that very different piece to see if there's any questions on the Partnership for Petersburg and DMAS's engagement there.
Yeah, Kim, thank you so much. There are actually several questions that got put in the chat as you were presenting. Would it be easier for you to just read them and respond, or would you like me to read them to you? What works best for you?
Yeah, I will skim them and answer. What changes have health providers and clinicians made to address their disparate treatment? Great question. I don't know that I can point to anything specific there, other than, just being willing to come to the table to have conversations about the lack of trust in the healthcare system that has come out of disparate treatment for people of color. In Petersburg, we know that there's many wounds in the community surrounding kind of that issue, and others related, that feed into disparate treatment. And that's where the trust building comes into place. And we are having open conversations on how we can be responsive to that, both in the clinic setting with providers as well as in the community. Very early stages of that work. We know that this takes time and intention and commitment across the board. Wish I had something concrete to point to out of the gate, but we're very aware of those issues and knowing that if we really want to move the needle, we need to figure out how to, heal some of those wounds and rebuild trust and engagement. But yeah, that's a longer term piece of the puzzle. How are these changes being monitored, coordinated? What kind of quality assurance is being conducted in the process? I think I touched on that maybe a little bit after you asked that question, with finding different ways to get more real-time input in the work that we're doing and tracking utilization, right now we're in the process of seeing what data we have available to us to be able to set what different outcomes we hope to see and influence in our work. Out of the gate, it was pretty vague. It's just increased outcomes, but we want to be more intentional than that. We want to set really concrete targets that we can put out into the world and be accountable towards moving into. We're in the process of developing those currently. We'll share absolutely once that is finalized, because I think that's a key piece, is having being able to report out on how we're doing and being accountable to that. What new resources were allocated to the residents of Petersburg. So many resources. I think I talked through much of the MCO contributions there. There's been so much more. I think that across different state agencies, there's been, different levels of investment. I'm not sure. They recently launched a website for the Partnership for Petersburg in the governor's office. And I think on that they might be sharing more regular updates on what those investments look like. So I will point to that. I'm sorry, I don't have the link off the top of my head to reference that, but I do think that that is available. Are charitable donations to Petersburg long-term commitments or one-time things? There's both. It depends on the level of the project. I think there's been lots of MCO engagement in physical spaces and infrastructure that are more long-term maintenance related and long-term involvement. And then there's one-off. We see that there's a community need for this resource. We will pull together and give that resource. For an example, the MCOs have really pulled together around a safe sleep initiative. We were working with the Petersburg Sheriff's Office. They alerted us that there was a string of co-sleeping deaths in Petersburg, where over the summer it was maybe 5 or 6 infant deaths happened as a result of co-sleeping, and which is horrible. And they're like, okay, we need to do some education here. The MCOs came together, decided to do quarterly events, gave a large donation of cribettes to help, and held some education sessions on safe sleeping practices. So that's more of a one-off, like, here is this resource to the community for infants to sleep safely in. Here's some education around that. But some of the other more infrastructure pieces are definitely more longer term, especially the mobile clinic, that will be dedicated to Petersburg in the long run. We'll have, ready access to the services provided there, and that will only continue to expand.
Kim, before we move to the next question, I just see that Adrienne is on and she has her hand raised, and I wasn't sure if it was another question, or I know you've done so much work in this space, Adrienne, that if you wanted to add some information. So I just wanted to give you space to do that.
Thanks, Sarah. I appreciate it. So what I'd like for everybody to understand is Partnership for Petersburg is not just on DMAS. This is an initiative with the governor's office that crosses at least 6 of the secretariats, even outside of Health and Human Resources. But even within Health and Human Resources, not everything is related to just DMAS. So for example, there are activities going on with the Department of Health, specifically the Crater Health District in the local area, where they have reopened their immunization clinic. They have reopened their men's sexual health clinic. So there are a lot of things going on with the hospitals. We're working closely with VHHA, the Bon Secours Health System in the Southside Regional in that area. We are working with the FQHC, with Paula down at the FQHC, where they are doing different initiatives. So it's not just a DMAS initiative. It's not just an MCO initiative. So I just wanted everybody, and I'm going to put the link for Partnership for Petersburg in the chat so that everybody can see, and you can go to that to see that this is a partnership across all aspects of the lives for people in Petersburg, even housing, you know, for example, things like bringing down the Ramada Inn. They're working around transportation with the with Amtrak. So there's a lot of things going on with Petersburg. So it's not just focused on what DMAS is doing. So I want you to kind of take a broader look at it when we're talking about Petersburg.
Thanks, Adrian. Absolutely. Let me skim these final questions quick. And yes, hopefully the website will help. And then I see, Jen, your question, or I skipped one, are there efforts for providers to expand hours of operation to make appointments available? We are working so hard on that. That's one of our primary focus areas of how we can increase access to, you know, evening hours, 1 weekend a month, having, you know, time available there. We know that's a need. So we're absolutely having those conversations. That's part of the provider engagement. Data available on the website. Working on that. Our Office of Data Analytics is working on some, you know, dashboards that we potentially hope to make public eventually once we land on the measures and the accountability piece. We'll definitely be sharing that. I think that is it.
Yeah, I think that was the last question in the chat, and thank you so much. I did just want to give space if anyone, we don't have to use the chat for questions, so if folks want to unmute and ask a question.
Hi, Sarah, this is Cheryl. The only other thing I wanted to mention is, and CHIPAC can help this. This is not an issue about some of the issues on maternity is across the state. We need providers to be willing. We know the women are working in hourly jobs. We know that. We need providers to make the commitment. And so anyone who's a provider group, we need that kind of heat. And we talk to that to make sure that we can get Saturday hours and evening hours. Now, it's interesting. We've seen that in the pediatric world. So we've seen pediatricians open up their hours on the weekend and open their hours at 6 in the morning and give hours for the women. We have not seen any OBGYN. We need to have that kind of discussion. And so maybe we need to have Nicole to talk to or others, and maybe the hospital system, which actually controls some of the big practices. So that's where, so Petersburg, to me, the reason we love Petersburg is that it taught us that we didn't see how Petersburg numbers were bad because we were looking at the region. And so when we saw the Richmond region, it looked okay. But when you look at Petersburg, then you see its issues. It taught us that if you look at a certain community, you can make a difference. But that also means everyone has to join hands. And so, Sarah, what I asked for is that, yes, we would love to see OBGYN's offices open sometimes on a Saturday to accommodate them. That would be helpful. And the second question everyone asks is, can we pay for people to pay for paid leave to leave, which is actually what Bond Secures has suggested. We cannot do that. Now, if any of you you want to, and you're a multimillionaire, that would be good. But Medicaid so far, we have not seen that in the country. Hope would have been the first person to have written it up if it was. Is that true, Hope? You would have done that. I just want to mention that. But Ali, you know what? If you want to have that donation, we will create a fund for you.
No, I really appreciate what you just said, Cheryl, which is absolutely, it's not just DMAS, but you're absolutely right. It's the providers really have to be pressured to meet the needs. And that's why I was asking some of those questions and really appreciate the time here on this call.
Kim, I had one last question. Dr. Brown's kind of data that she put in there about kind of the younger patients tending to have an even higher kind of rate of not accessing prenatal care and not being able to take off work. Are there different interventions being tested for different age groups? obviously, you know, teens who are pregnant who are in school could maybe get better, like more accessible services through the school clinic model. So just curious if at this point kind of models have gone down to that level of detail.
Great question, because we're gearing up for that. I think I talked a little bit about the data deep dive that we're currently doing to really understand who are our members that are utilizing services, who are our members that aren't, kind of what age group are they in, what other information do we know about them that can help us target interventions differently. So we're currently doing some investigation there to figure out what that could look like, because we know that it will look different for the different populations that you mentioned, but haven't dabbled in that in a very targeted way yet. Some of our MCOs might be doing that on their own through their own care coordination, care management, because they have, you know, very comprehensive member data, you know, at their fingertips. And so we're kind of now coming to the table looking into that, and look forward to reporting out in the future of, you know, what those targeted interventions have been.
Sarah, they can't do it in Petersburg because the FQAC does not have admission practices into the hospital. So yes, there's a school clinic that can, and it's also an FQAC, but she can't admit. So when you have those discussions, you got to go all the way through the whole line. So happy to discuss it, but you got to make sure that the person can actually do everything. Otherwise, what you have is a terrible handoff.
Right, right. Yeah, absolutely makes sense. There's a lot of factors to go into it. And I certainly just threw that off as like a top of my head example.
No, I know. Only reason is because we went to visit the school clinic and I went to visit the FQAC. So right now, I think the three of us, that's why you hear it so passionately. I could go and drive to Petersburg blindly. And so does Kim. Okay. And Kim could do it without her hands at this point. Okay. So if you have any questions, we can tell you down to the street level of what. And Kim knows all 33 women who are pregnant each month herself. So happy to discuss it. Because we really are. And answer the question for other people. Please don't ask us to replicate this right now. Okay, I had a nervous breakdown yesterday. Please, we can't. We'll be happy to share the findings, but don't suggest. Oh, by the way, why not Wise County right now? Okay, not right now. Is that fair, Sarah?
I appreciate the not right now. The right now part of that sentence is
right now. Like you know, this decade. Okay, this decade.
And
well,
I think oh, sorry, Sarah.
No, please go.
I was going to say, I think there's a good transition to the other piece. I said I was going to give the little procurement update with the last comment in the chat, reminded me of that Susan Brown put in about potential, you know, engagement with VBP on Petersburg, and made me think of, yes, let me give a very, very brief overview of where we are in the procurement, because we're hoping that that is an opportunity to kind of leverage that to align with all of the different agency priorities and the governor's priorities and activities going on. So I wanted to touch real quick to thank all of the CHIPAC members who gave us feedback when Dan presented in December. We were really grateful for the wealth of, you know, ideas, opportunities, challenges, needs that you all presented. I think we got very diverse feedback from a wide variety of associations, provider groups, had some member feedback in there as well. And just wanted to say, you know, we really took that feedback seriously. We used that to shape what our procurement priorities and focus areas are. And we can't talk about that yet, but when the procurement goes live in EVA on August 1st is kind of the date we're working towards currently. You'll be able to see how all of that feedback translates into improvements and innovations that we've built into kind of the future of our Medicaid managed care program, and that we're in solutions that we're looking for potential MCOs to come to the table with to meet some of these challenges and needs and help build on these initiatives and projects going forward. So yes, thank you to everyone for the feedback. We will be sure to share information once it goes public, like I mentioned, in August, so that you can see, and at that point we can have kind of more targeted conversations once everything is public about how we can continue to build and innovate. And then, of course, kind of on the other end of this procurement, once our potential MCOs have been chosen and have come to the table with additional ideas and innovations as well, we're excited to share that work. Trying to also looking to see if there's any additional things to add there. And Cheryl and Adrian, I don't know if you have anything additional to say there. We just are very, very close. Yes.
So it's kind of going back a little bit about just trying to get these women to the appointments for the OBGYN and afterwards after they've given birth. So like I know when VACHA had their collaborations with DMAS, it was kind of news to us that Medicaid actually could pay for transportation to get these appointments. But the thing is like, I mean, again, it was like news to us. So if it's news to us, it's probably news to the patient as well. Do y'all do any advertisement about being able to order like Ubers and Lyfts? Because I know that's like a huge impact because a lot of people, patients say, I can't get to my appointment. I don't have transportation. My ride didn't come. So I was just seeing if y'all did much advertisement on that.
Cheryl or Adrian, you might be able to speak to this broadly. I can mention.
Okay, let's talk. Okay, one, the question is, yes, the plans do tell all everything we have says the transportation is covered. And also the caseworkers who work with the maternity do say that. So we ourselves, DMAS, that is what we really give to the health plans. And when they do contact the woman, that they do tell her she has all these options, including Uber and Lyft. Most of our health plans do Uber and Lyft if that's necessary. The big thing we have found, you're correct, is though, has been so far, has been two things. One, young women believing that they don't need prenatal care. That is one thing. Two, we see the same thing with unwinding, getting the same group of people to open up letters. We have found that to be difficult. And then three is to make sure we have a current cell phone number so that the plans can stay in touch. Because if they do, then they could do texting and things like that they want to do in order to keep in touch. So that's why we're glad this group is engaged all the time. And I'm glad. And Martha, if you can come up with any other suggestions, because right now we do a targeted maternity letter, in addition, DMAS does, in addition to the health plans, that very clearly states that you can get transportation. That's all, and then Kim is doing something just for Petersburg. So we are trying, but if you can figure out a way to get young people to open up an envelope, that would be very helpful.
Thank you.
Okay, open the envelope. I don't know why they are opposed to envelopes and talking to adults.
I'm one of those young people, Cheryl. So
do you open the envelope?
Sometimes.
Right. And I'm going to tell you what I said to everyone about unwinding. If you're a state employee in May, you got a big envelope that told you to pick your health plan. And when I asked my state employees, my own team, only 20% of them said they opened the envelope. Okay. So keep that in mind, that we're sending all this information and we have to get people to open the envelope. That's going to be my new crave. All right, Sarah, I'm sorry. Goodbye. I'm not going to talk anymore. I'm going to go away.
You're always welcome to come and talk at our CHIPAC meetings. Thank you very much for coming and sharing and adding more context to all those points. We appreciate it. In the interest of time, we do need to move on. Our next is a relatively brief update, I believe, from Will Frank about some new resources that DMAS has put together for legislators and about legislative districts. So Will, I think you're still on here, and if you are ready, please take over.
Great. Can you hear me?
Yes.
Okay, perfect.
I don't know if you have slides. The old slides are still up. So if you do, if not, we can maybe stop the screen share so we don't have the old slides up.
There we go. If it's okay, I'm gonna share my screen just to show you the website. So the quick version of this, I came and talked to CHIPAC. Last time we talked, one of the questions we got was legislative outreach and how we are educating legislators on different initiatives from DMAS, like unwinding and basic Medicaid 101. Since then, we launched this website. It is found, if you go to the DMAS website, under About Us, you'll see Legislative Office Resources. And we sent this out to all 140 legislators and shared it with some stakeholders. This is to provide legislators with some basic tools to help them with constituent assistance, learning about Medicaid within their districts and some of DMAS's key initiatives. You'll see the first section takes them to a portal that helps them fill out constituent assistance, and that goes to us, and we can direct it to make sure that we get the correct eyes on it and get a response back to them. Helps track it, helps keep things organized. I'm going to skip the middle section and go to the end. I'll get back to the middle section in a minute. We also have some brief one-pagers on some of the key initiatives that we're working on this year. Again, these are just to provide legislative offices with some basic knowledge on Medicaid and our initiatives. And then the big thing that we want to show you is we have some dashboards we put together with information on congressional, House, and Senate legislative districts, Medicaid enrollment per those districts. And the kind of neat thing is, and some of you might really appreciate this, is that this is based on the new current district legislative districts after redistricting. So these are what they're currently running on right now and what the congressional delegation is currently representing. But you'll see if you open that up, it'll take you to a really great dashboard. You can go ahead and click the district. It'll go ahead and give you information about the population and some of the breakout of the Medicaid enrollment within that district. And so this is, again, we've sent this out to all 140 offices to make sure that they are going to know about their district. We've already gotten some really great feedback and comments from legislative offices. But also kind of on the other side of this, for all of you on CHIPAC and anybody else out there, please feel free to share this. Please feel free to use this in your advocacy, in your conversations with legislators. This is not just a DMAS tool to use for us to educate legislators, but we're hoping that you'll use this as well when you're talking to legislators, and it'll be a valuable tool for everybody. So that's the quick version of our legislative resource page. As things might change, we will probably update this as new initiatives roll out, things like that. But that is our new resource page. Any questions, comments?
Well, there's one in the chat. What time period is the enrollment data from?
So so this is as of, I think you can see here, this is as of kind of mid-March. We're still working on how often this will be updated, whether it's going to be quarterly, but this is data that is as of the kind of mid-March, right before we roll this out.
Well, I will say we at our enrollment program, the Navigators, we did a mailing or an emailing to all the legislators just with flyers and offering, to be a source of assistance during unwinding, especially for folks who are transitioning to the marketplace or just have questions about the process, and uses data and pointed legislators to kind of these resources that y'all had put together. So we definitely use them and appreciate that they were there and that you did all this work to get all that data kind of down to the district level. And Kelly also just points out that it's really great given the large turnover that we're going to have in the General Assembly. So a lot of new members, they'll have this data and resources right there for them, which is, really big because Medicaid is big and complicated. And so it's great to make sure that they just have kind of easy access to that information.
And great, and thanks Kelly and thanks Sarah. And you'll also see on Jessica's presentation, we've kind of added this to slide decks as well. We did a presentation for the Joint Commission on Healthcare, and this was on there as well. So again, we've gotten some good feedback that we know some legislative offices are using this or looking at it. So we're hoping that it makes a difference.
Great. Does anyone have any other questions for Will while he's here? Or that kind of concludes the end of our DMAS presentation. So just kind of last call for questions about any of the many items that we touched today. All right, I think we can move on. Well, thanks again for coming and for all the work putting this together.
Thanks.
The next item is just committee discussion on CHIPAC committee priorities for legislative or budget requests going forward. This kind of came out of last year. There was a lot of interest in being a little more proactive and upfront with guidance, and instead of just receiving information after things have been done, being able to kind of work as a group and provide recommendations to DMAS, to the HHR Secretariat. So last year we did a kind of a poll within a meeting, had some discussion, and ended up submitting a letter to the agencies and the Secretariat with some budget recommendations for them to include in their budget package for the upcoming year. It was in the June meeting that we did this because, you know, at this point in time, agencies are getting these together to submit to, you know, go start that review process. The option is that we can do something like that again. It's obviously a little bit of an interesting year with the budget because we don't have a budget from last session that's finalized yet. So as a committee, we could also decide to write a letter recommending or recommending specific aspects of either the standing House or standing Senate budget as it relates to maternal and child health. Or, you know, we can continue just to have a kind of a robust conversation about what different policy items we think would be good and use different avenues to discuss them with the state and recommend them to the state. I will say in our previous meetings, as well as our executive subcommittee meetings, the list of things that we came up with is much bigger and broader this year. Some are more specific and detailed, some are more general. So, you know, I would recommend that if we are going to author a letter and submit it, it include recommendations that are specific. So, for example, instead of just like raise rates for behavioral health, identify a particular service that we think needs to be promoted or something like that. The list of recommendations that kind of the executive subcommittee pulled together from things that have been discussed in previous meetings, as well as recommendations that were made last year that have still not been, did not make it into the budget or through the legislative process, are included in the packet of information that Hope sent. It's the second to last item in there. It's page 17 of the PDF. The other kind of just confines that we worked in last year, I know state agencies as well as kind of state adjacent partners like JCHC can't make recommendations. And so they certainly last year were immensely helpful partners in helping us understand different options and giving us technical advice as we were discussing different options, but certainly they are not allowed to work outside of the standard agency process for recommendations, which we understand and want to certainly honor that and make that clear. And that obviously as CHIPAC members, we kind of are always looking through the goal of just improving maternal and child health. So in what avenues are there to make the largest impact in the health and the lives of pregnant individuals and children in Virginia through the Medicaid and CHIP programs. And so that's just kind of how I was hoping to tee up a little bit of a conversation in terms of here are the policy options that have been brought to us, here are kind of the different timeframes we're in as a state for what agencies are doing, and options that we as a committee could take, or just, you know, use this time to have a little more robust conversation about these various options that have been brought up in previous meetings. I know if anyone else who was at the last executive subcommittee meeting wanted to fill in anything that I had forgotten, or maybe to have some of the conversation yourselves, it would be, I would appreciate that. That'd be great.
Yeah, I could just speak a little bit to that. And so I think these are some of the options that we've kind of gathered between recommendations that were not recommendations from last year that were not passed or included in the budget. Still waiting for a budget, but and then just some other things that we've been hearing in CHIPAC meetings and just in our other work. So I think it would be really crucial that if we are advocating for something, it should be specific. It should be actionable, and it should be, kind of time sensitive, right? So kind of what Ali said in the chat there. So these are ideas. I think we're happy to kind of talk through other things that might come to mind, or if there are some of the more general ideas here. So for example, there's like um, you know, reimbursement rates. What if there's some type of metric that we can use, or specific population covered, reimbursement rates that we want to advocate for raising, and specific numbers. I think that's all a conversation. So yeah, that's pretty much our idea in terms of like gathering these thoughts and presenting them today.
If no one else has kind of thoughts on that, I can just run through really very high level what the different options are. I tried to kind of bucket them as I put this document together. So the first bucket would be the coverage expansions. So last year, CHIPAC did recommend both to create a state-based option to cover children regardless of immigration status. So right now, Virginia has really adopted all of the various CHIP options to cover non-citizen children. The main kind of category of individuals who just cannot be covered due to federal rules by CHIP or Medicaid are individuals without immigration status, as well as having deferred action for childhood arrival status. There's a proposed rule at the federal level to change that aspect of it, but the undocumented individuals are still just unable to be covered. So there are several states that have chosen to use state funds to create kind of like a state program that mirrors their Medicaid and CHIP programs for these children. TCI has done a lot of work on it. I know Freddie's done several issue briefs. So we link to one of those for more information on that. The second one in this bucket that we recommended last year was just generally increasing our income limits for children and pregnant individuals. And you can see we're kind of bottom of the mid to bottom of the income levels for coverage. One note here is that the pregnancy related income cannot be higher, that like pregnancy CHIP can't be higher than kids CHIP income. So we can raise the children's, we could recommend raising the children's income level or the children's and the pregnant individuals income limit, but we can't recommend increasing the income limit for pregnant individuals and not increasing the income limit for children. I'm not sure why we would do that, but that is one kind of just federal restriction there. The next is just recommendations for the implementation of current initiatives or requirements. So provide recommendations for maximizing some of the federal options that came about through the Consolidated Appropriations Act of 2023. There's some requirements in there for providing services to juveniles prior to release from incarceration and shortly thereafter. All of the CAA kind of, for example, the CAA directed state Medicaid agencies to do this, but not necessarily state corrections agencies to do this. So if we wanted if we had ideas for a specific way of implementing this, or how the MCO should be involved in this or not involved in this, those types of kind of very specific things, because this is a requirement, it has to go into effect. But do we think we have good ideas on how to make it the most impactful change that it can be? There is also an option to allow children who are incarcerated with pending charges to remain covered in Medicaid or CHIP. To be honest, I don't know how many kids, to me, I feel like we need a little more information in terms of like the impact, our children's families calling and dropping coverage when they're in this situation, what's happening. I'm not sure I kind of have the data just to know what the impact of that change would be. But we certainly could recommend it, or we could recommend the state look into accessing that data to see if it would be a beneficial change or not to make. one recommendation that came out of the Safe and Sound task force, and I'm not sure if folks from DMAS who are part of that task force are here. They might be able to speak to this in more detail than I can. But right now, when a child enters a residential facility, they're moved out of the MCO. And so a lot of the children that Medicaid enrolled children who are in residential facilities are foster care children who are also in foster care. And that really kind of disrupts the continuity of care, because when they leave the residential facility, it takes a little while for them to get back enrolled with an MCO. But the MCO kind of has already lost the data of the previous services that that child was getting, the previous care plan. They have to do a new assessment. So it takes a while to get those services kind of lined up again. Whereas if they were able to maintain this MCO enrollment, the hope would be that these services would be able to kind of go right back on as soon as that child leaves, right? Because when a child is leaving such an intensive, like therapeutic environment, having a large gaps of services, having to change providers, having to do all these new assessments again, can be really disruptive to any kind of like effectiveness of the treatment that they were receiving, right? It's already disruptive in a change of environment. Our foster care youth tend to have a lot of changes in environment and disruption already. So any kind of continuity that we can keep in there is great. Then the next bucket is just streamlining Medicaid processes for better access. So just looking at our systems and saying, where is the system or the process preventing coverage, not necessarily the eligibility, right? And so one is just how can we continue to help individuals who are leaving incarceration, particularly pregnant individuals, if they're leaving incarceration or if they've been furloughed, so they're temporarily leaving incarceration, get into full benefit Medicaid so that that labor and delivery can be covered, and then that child can be automatically enrolled in coverage. So we're just making sure these eligible people are getting in a little more quickly and easily. Or merging the CHIP and Medicaid children's programs. So they're separate programs right now. There's budget language from a few years ago where DMAS requested this, but having it designed the way it does just creates some idiosyncrasies that make it a little bit harder to administer. And so merging them would kind of ease that, streamline that, and it would extend some Medicaid specific benefits like non-emergency transportation, like we were just talking about, as well as EPSDT to CHIP enrolled children as well. Then multi-year continuous enrollment for children. So the Consolidated Appropriations Act of 2023 requires that there's 12-month continuous enrollment for children. So basically, what we have that for our pregnant individuals right now. So when you're enrolled, we say you can just stay enrolled until the end of your postpartum period, even if you have an income change or another circumstance change that would generally make you ineligible. We will have that for children, I think it's as of January 2024. So once a child is enrolled, even if they report an income change, that child will remain enrolled for 12 months. Some states, Oregon and Washington, have multi-year continuous eligibility. So really preventing churn that happens at renewal for kids who, generally speaking, remain eligible. There's, more kids lose coverage because of the process and not because of eligibility. There, in one, I think it was at the last CHIPAC meeting, we discussed hospital presumptive eligibility, where a hospital can basically say, okay, we've done this assessment. There's a criteria for being a hospital that's allowed to do this. We're going to enroll you in Medicaid for this temporary period so that you can get coverage more quickly. And then that person does need to complete a full application to get enrolled for a longer term ongoing coverage. Federally, other entities can do this. And so if we wanted to recommend that entities that are already interacting with likely Medicaid eligible individuals with access to their information, like a federally qualified health center or free clinics or Head Start programs, could also be identified as presumptive eligibility entities to help those families get enrolled in coverage. And the last kind of specific one on the list is express lane eligibility, where we would use data from programs such as SNAP. Maryland just passed one where they use SNAP. So a SNAP application that gets most of the information for Medicaid is essentially the base for a Medicaid application, and it helps those folks get enrolled without having to do duplicative applications. I do find as an assister, folks tend to apply for like one program at a time because that's the thing that they're most concerned about. And then they go back and like do the full application for another. So this would just help in that situation where even if they were focused on one, it would be near, like it would almost be doing a full assessment for other program as well. And then, you know, the other ones are a little more broad, adding community health worker benefit, adding additional home visiting services, reimbursement, just general reimbursement rates. I know we've had lots of conversations over the years about various reimbursement rates. I know a lot has been done for some services, at least in the last few years, through the General Assembly. Looking at the implementation of school health services as well. CMS has put out a lot of guidance on that in the last even several months. And so hopefully, you know, as a state getting that program up and running, I know there's a lot of members who've been very interested in that as well over the last few years. And then just generally behavioral health and right help right now. And I don't know if Emily Griffey had more that she wanted to add on that. I know she knows a lot more about that than I do, so I don't want to misspeak. But other than that, those are kind of the things that have come before us. I think the question is, you know, do we as a committee want to do a letter? And then if so, how do we kind of focus in on the items that we think we would like to recommend? And I'll just note, because this is like a public meeting, we can't make these decisions like via email after the meeting. And so it would have to be during this meeting or during our next meeting. We kind of tee up something to be decided at the next meeting, although for the next budget round that might be a little late. It doesn't mean we can't kind of still, there's lots on here. We could still kind of tune a letter or recommendation to at our next meeting. So I will stop talking and open it up again.
And just a quick note as we're waiting for this next, if there are amendments to the budget for this year, there's a couple of items that might might be included or are in the possibility to be included that might impact some of these. So the state-based coverage option for children in regards to immigration status was included in the Senate budget. There was also a study to look at community health worker Medicaid reimbursement that was included in the Senate budget, I believe. And then there was some reimbursement rate stuff that's also in the budget, thinking about behavioral health reimbursements for in the Senate budget, and also some personal care respite reimbursement rates in both the governor, House, and Senate. I want to say. And then finally, behavioral health, the Right Help Right Now. I think all of those provisions were included in the House and Senate budget with maybe some additional funding around certain things. So that, I mean, that's all kind of like a messy kind of gray area right now, as you know, we see what happens with those amendments to the 2-year budget that are supposedly being discussed at this moment. So just wanted to flag that.
The Senate budget also has, I believe, funding for a position to provide education and assistance to school systems on how to implement some of the billing, being able to bill Medicaid for Medicaid services delivered to Medicaid enrolled children beyond those who have an IEP, which is what it was kind of previously limited to. So there's a little bit of funding to kind of support that program growth as well in the Senate version.
Sarah, given the restrictions around meetings, could we vote today to agree to advance forward a letter, but members would have the option to sign on after viewing it?
Yeah, I think that's fine. I would request that there's a little more specificity if the letter is for the current budget that's under negotiation, for, you know, recommendations for inclusion in a budget package for next year, or something else. But I think that's a great way to approach it, especially given the time. I know we're over, so, or close to over. So, I mean, I guess in the chat, if folks have opinions and want to vote on what we want to target. The current budget that's under negotiation, the next budget for that would be going forward in General Assembly 2024, or another option, and then that will kind of help us limit it down, unless anyone opposes that.
You all who are currently in it on the day-to-day can probably best advise on that. I can't, it strikes me that we might be most effective speaking towards the next biennial budget, which is that process is underway to develop it. And if our feedback is submitted and it could weigh in potentially to current budget negotiations, great, if the timing works out. But long-term play, we might be more effective there just because there's a lot tied into the current budget negotiations. And I think a lot of those opinions have been weighed in already. But I am not a lobbyist.
You used to be.
Thanks, Kelly. I agree with that. Recovering lobbies. Yeah, I agree with that. I think if I think they're pretty advanced in their negotiations on this budget at this point. And if we recommend something that they choose to include in this, like, fantastic, right? And it just shows how important we feel about that change being made. But I also don't want to, like, I'm not, I can't tell you what's going to be included in that budget. So I think it's just safe to move forward with thinking through, like, assuming, that we'll just look at next year or next biennium as our target, and anything that kind of crosses over, coincides with this budget is just a happy coincidence. And we would have been successful with a recommendation early on in the letter's life. So yeah.
Great. Well, I'm hearing no other opinions or dissent, so I think that that settles that question. The next would be, there's just a large number of items here. We obviously cannot include them all. I think last year we had 4. I saw Ali in the chat recommend 1 to 2 specific recommendations. I'm trying to think, because I don't want to make a decision for the group in drafting a letter on that. I'm happy to draft a letter, but certainly would want guidance from the committee on which we could mirror just what we recommended last year, but removing things that were no longer applicable, like the 12-month eligibility continuous coverage, because that's going to be federally required now, or we could trade that out with a multi-year continuous coverage, which kind of would be the next step from that as a committee. That was something that we did recommend previously, so we could just kind of promote the next specific kind of like iteration of that, and having a multi-year option for that. Or we can do a quick vote in the chat.
I think I lost track of where we are right now in the decision point. Are you suggesting, do we vote in chat around specific items, or is that, because that seems hard unless we can do like a polling function or something like that. But I don't mind saying that I feel very strongly about, keeping the recommendation of making sure that children are eligible for benefits regardless of immigration status. The other ones I would just have to think about a little bit more, I think, but that, but I don't know what the best way to make this happen in this format, if we're trying to narrow things down. Is that what we're trying to do?
Yeah, I think I'd love to hear feedback now, and I think the decision the group, it sounds like everyone would be comfortable with making recommendations for the budget for next year, legislative recommendations for next year. I think given time and format, having just open conversation right now at our next executive subcommittee meeting, we can regroup and put a plan forward for the full committee at the September meeting. Does that sound good for folks? Great. We can do that. Shelby, I've certainly, we've noted that Cover All Kids is a priority for you. And if other folks have things that they want to mention now, or always feel free to email me, Hope, the other executive subcommittee members, Freddie, Heidi Dix, Ali and Emily Roller, one or all of us, and we can kind of, our meeting is in about a month, get together some proposals and get it out to the group prior to our next full committee meeting.
Yeah, and just to add some context, like we were thinking about like polling options and you know, bumping into the fact that, you know, we couldn't make this decision on like a Google form, for example, but it had to be during a you know, recorded meeting, and the limitation that WebEx has apparently with polling, and then like how, you know, how are we gonna list the polls, and if especially if folks have ideas. So just to reiterate, you know, with Sarah, I think the subcommittee is happy to kind of draft something and put forward some of our, like, what we think and what we hear from folks are priorities for final approval next meeting. But I think just generally, if folks feel really strongly about something, like, I think this is the time to mention it, and we would definitely like take that into account as we draft that letter. So I think.
Can I just ask a quick question though? Because I think I heard you also say that, you know, if we wait until September, then we're running kind of close in terms of, you know, as people are making priorities, and if we want folks to really consider the recommendations, is there a danger in waiting until the September meeting, or do you feel like we're just going to be fine with the time? Or because if not, I mean, I know that we only have a few minutes, but is there some, anyway, I'm not trying to be hard, and I know that people need to leave, but I also don't want to delay things if it's going to make it so that the recommendations won't be, you know, timely enough.
Hope, I don't know if you had thoughts just on the specific timing aspect of that. I know you can't chime in on a lot of the other things, but just in terms of timing. And Shelby, yeah, that is kind of the challenge with where we ended up. Just last year, we had a lot more clarity and consensus around specific things, so it was a little bit easier to get something drafted by the June meeting or shortly thereafter. There's just been kind of various roadblocks this year, one of which including we don't even have a current budget. So and I will say, even if it isn't specifically budget, it recommendations for the legislative process can still go forward, and that is not, doesn't get kicked off until January of 2024. As a committee, we can always recommend things that would be legislative in nature, as well as send copies of our letter to specific legislators or committee heads prior to that process kicking off as well. I think ideally, if we got it, I'd rather have a good consensus and a good process, and if we have to kind of make the recommendation slightly later in the process, then rushing something just to have something done and not really have the appropriate time to get feedback and build consensus around those things. That's my personal preference, certainly open to other opinions on that.
And that makes sense to me, by the way, so thank you.
Okay, so we as executive subcommittee will go back, we'll do that work, and we'll come back to the committee. Hope has put in the chat just the details for our next meeting, which will be September 7th. It is in person, so please do remember that we have to have quorum to have any votes. let Hope and I know if you cannot make it to that meeting. There's also the exemptions for missing meetings that we voted on a couple meetings ago. And so if you forget about all of that, it's fine. Let us know. We can kind of send you the refresher information on that. But for the in-person meetings, now we do have to have kind of that in-person quorum. So please mark that down and let us know if you do have a conflict. And I think, and yes, substitutes, thank you, Hope. Sending a substitute is also a great option, and that does kind of count towards the quorum. So I appreciate that reminder as well. And then I think that's it in terms of committee business. We will open it up for public comment, which will be the last item on our agenda today. Without any, Hope, is there any kind of other administrative business or anything I've missed before we close?
Nope, I think you've got it. No more announcements on my end.
Great, thank you. Well, thank you all so much for your time today. And I'm sorry we've gone a little late, but I do appreciate all of your feedback. If any of the presenters are still on, thank you so much. We learned a lot today, and we always appreciate everyone's willingness to give email addresses and let people follow up with questions. So I hope everyone enjoys the rest of their afternoon and have a great weekend, and we'll see you in September.